The next speaker is Anusha Chawla. Is she here? She will. She will speak on serious detachment of macula associated with chickenpox, a novel finding.
Good morning, everybody. The topic of my today's presentation is serious detachment of macula associated with chickenpox, a novel finding. So chickenpox is a common viral illness caused by varicella zoster virus, which is usually self-limiting. And the well-recognized cutaneous and systemic manifestations have been reported. Ocular involvement in chickenpox is very rare, which is typically limited to the anterior segment, most commonly causing acute anterior uveitis, may also lead to keratitis, episcleritis, ophthalmoplegia, rarely involving the posterior segment. If at all involving the posterior segment, it generally causes acute retinal necrosis involving the periphery of the retina. In our case, we have discussed an isolated macular serous retinal detachment in association with chickenpox, which has not been previously documented in literature. So beginning with the case presentation, ours was a 20-year-old male who presented to us with chief complaints of diminution of vision in left eye. 10 days after having fever with rashes, the diminution of vision was insidious in onset, progressive in nature, associated with pain. The progression of rashes was as expected for a rash of a chickenpox. The medications were as shown below. The general examination was that the patient was febrile and has scabs which were crustings present diffusely over the trunk and the proximal limbs. The ophthalmological examination for the right eye was within normal limits. For the left eye, the patient has a severe diminution of vision with a vision of finger count close to face. The anterior segment was unremarkable, and the fundus segment has the findings as shown in the figure, where we can see retinal folds which demonstrate serous macular detachment. An SD-OCT was done, and that confirmed the finding of macular detachment with a central subfield thickness of 355 micrometer. A fundus fluorescein angiography was done, which showed a hot hyperfluorescent disc. Investigations were done. Varicella zoster virus DNA PCR and ELISA was done, which came out to be positive. And the treatment that we gave to the patient was we kept him under observation and continued his oral medications and monitored him on a 1 monthly follow-up, where we observed that the detachment was progressively regressing. At a 3-month follow-up, when the patient came to us at a 3-month follow-up, the vision was restored to 6/6, and there was complete resolution of serous macular detachment on the fundus, as well as the central subfield thickness on the OCT was 232 micrometer. So the possible mechanism of the transient isolated macular serous detachment that we see can be explained by the varicella zoster virus replication at various levels. When the virus replicates inside the infected T lymphocytes, the T lymphocytes can lead to inflammation leading to exudation. It can cause replication in the capillary endothelial cells, and when the virus exits the vascular system, it can lead to vasculitis. The replication in the RPE can lead to the compromised integrity of the RP, leading to the compromised integrity of the outer blood retinal barrier, leading to, again, exudation and the serous macular detachment. So the take-home message for us is that although rare, ocular findings have been reported in cases of chickenpox, and this highlights the need for careful retinal examination and fundus evaluation in systemic viral exanthems like chickenpox. Thank you.
Good. So this was just a single case?
Yes, sir.
So what is your working diagnosis? Are we dealing with some kind of optic neuritis or something?
Sir, optic neuritis has been previously reported. We are dealing with the involvement of the serous macular detachment.
No, but you said the disc also hyperfluorescent.
Yes, sir. So, but that is not a novel finding that we are focusing on in our presentation. The novel finding is that the macular, there was a transient serous macular detachment that has not been reported before.
No, but even with optic neuritis, the fluid
Yes,
can
sir.
trickle down up to the
Yes,
fovea.
sir. Yes, sir.
So what was the cause for the NSD?
Sorry, sir.
What was the cause for the serous detachment to happen?
So the mechanisms that we have that have been proposed are the replication of the varicella zoster virus at various levels. When it replicates at the level of T lymphocytes, it can lead to inflammation and exudation. When it replicates at the level
so
of
wouldn't you call it RP epithelitis? RP epithelitis has been reported. So is it not, could it not be RP epithelitis? Secondly, you're talking about vasculitis,
Yes,
but
sir.
you've not shown any peripheral scans and of vasculitis. And why would vasculitis again come with, because RP epithelitis is known to cause NSD, present
sir.
with an NSD.
Yes, sir.
But vasculitis per se would not primarily cause, this thing. But I'm not very sure because if there's vasculitis, because you
Yes,
said that the
these are the
disc is hot, but it is not leaking.
Yes, sir, it is not leaking.
So hot disc is usually called when it is leaking.
Yes, sir, but the disc is hyperfluorescent. It is not leaking, but it is hyperfluorescent.
Yeah, so the mechanism I think is a little this thing. I mean, I agree to what sir is also saying. It's definitely inflammatory.
Yes,
But
sir, it is
then,
definitely inflammatory.
I think you should go deeper into details as to what is the cause for the NST to come in.
Yes, sir.
On fundus fluorescein angiography, you see some pattern for serous detachment? On fundus fluorescein angiography, there was ink blot pattern or something else like that?
No, sir. No, ma'am. No, ma'am.
So
No
that
leakage.
is what-
Any
so-
visual evoked responses were done?
Sorry,
or-
sir?
Visual evoked responses or multifocal ERG, anything was done?
No, sir.
Thanks a lot.
Thank you.
Thanks.